basically need to know everything about Cat 2. You need to have Cat 2, and then this session we're going to do the categories. And also, you want to know the cranials that I teach you, you need to know the specific things about it. So anyway, these are the muscles we've covered so far. I think this is most of them. QL on there. I think we did QL, quadratus, lumborum last. So this is what session 1. If you remember, we talked about the sort of the overall, the big picture of the AK approach, and got into the basics of muscle testing. And we talked about the 2 main categories of reasons muscles can be weak. The muscle itself and its components have something dysfunctional. That's going to be like the triad of sprain, strain, and then this session we're going to learn compaction. There's 2 main kinds of post-trauma kinds of things that we treat with AK, and one is involves the triad of sprain, strain, the shearing type injuries, and then the other involves more compaction type injuries. And we're going to learn that here really quick. And then, so if a muscle is weak because of its own components, its tendon, receptors, its musculotendinous, GTOs, the muscle spindles, which are in the middle 1/3 of the, concentrated in the middle 1/3 of the belly, or the attachment points. If there's fraying or the dislodgement of the fibers where it ties into the periosteum, those can cause the muscle to be weak, and those are local problems with the muscle. The other category is things remote to the muscle, and that involves its blood supply, its lymph drainage, the acupuncture meridian that muscle is on or related to, cranial function, and of course, and so vascular, lymph, electromagnetic, nerve supply, and cranial are all the vast array of things that can cause a muscle to be weak, that other than the muscle itself. So that's I kind of wear that into the ground. That's the idea from session 1. We talked about the 5 factors. Everybody clear on that so far? 5 factors and/or muscle local. Sometimes you got both. Section 2 review. Oh yeah, we learned about basic cranials. Switching. We talked about switching. Remember, we talked about ocular lock. This is like the quickest way to clear switching. Check for ocular lock, and usually there's a need for some resetting in the upper cervicals. That's kind of a quick and dirty way to get people sort of tested. Also, another way is to just have them cross crawl. A lot of times that will kind of clear their nervous system. And then of course the third way, I don't know if we covered this very good. The third way is where you massage just right above the umbilicus and right at K27 on both sides. You do that for maybe a half a minute each side, and that a lot of times that will clear them enough to where they're holding, they're testing. We talked about adrenals. Know the adrenal nutrition for your test. Know, you guys know this anyway, but know the difference between what goes on with the cortex and what goes on with the medulla. Plus, went along with the gait. Remember we did gait, and we looked for muscles that are supposed to inhibit in gait. And if they didn't, then we started looking for why they aren't properly inhibiting. And usually it's where the dura attaches. Remember? Cranium, C1, 2, and 3, and then down firmly at about S2. And everything else is the dura is pretty loose in between. But those areas are where the dura can get torqued. We talked about dural torque. And that's involved in gait issues. It's involved in the plus. The plus has to do with the inborn torsion that the spine goes through when we go into flexion. It was discovered that we don't just go straight into flexion. We actually rotate, and we tend to rotate one way. And there's all kinds of ideas about that. It has to do with the original spiraling, as we develop in the womb, and then it's also allows us to sort of spiral out of the womb. People they attach all kinds of interesting narratives to that, but it is a phenomenon that we can use to see if dural torque is being somehow if the dura is being torqued. We don't want the dura to be. It gets torqued every time we move, but we don't want it to stick that way. Anyway, any questions on any of this? How do we screen for cranial? You're examining the person, you kind of do posture, and you got some stuff. Oh, that might be weak. You go and you test a muscle, and it's weak. Is that our camera?
Yeah.
And so at first you have no idea why the muscles are just weak. Maybe they got a high shoulder and the lat's weak, and that kind of makes sense with posture and whatnot. But why is the lat weak? Is it weak because the lat itself is weaker? Is it weak because of a cranial syncope? Is it weak because of dural torque, which is causing a disruption of how it's signaling back and forth? So it could be any number of things, but how would we screen for cranial? How would we screen for O and up? Muscles weak.
TLing.
TLing, thank you. You would TL, have the patient TL the O and I. That's a good place to start. How would we TL? How would we test for whether it just needs a good muscle spindle reset? Go to the middle belly of the muscle and push out. TL the middle belly of the muscle. How would we screen for cranials?
Bilateral.
For one type, yes. For yes, you're getting ahead. You read ahead. That's for temporal lobes. But any muscle can be screened to see if it has a cranial involvement, and that's where you have to take breath in. Have them take a breath in and hold it and see if it changes. Now you can also find sometimes you'll have somebody take a breath in and a strong muscle will eat. That's something too. But way to screen for cranials in general is have the patient breathe in and hold, see if it changes the strength of the muscle. Now, last session with spinobasilar, remember we learned inspiration assist, which is kind of the most basic cranial. And then we learned spinobasilar, which is like inspiration assist, expiration assist, like only like on steroids. So it requires a forced inspiration or a forced expiration to reveal it. A lot of times, if say this lat is weak and a breath in doesn't strengthen it, go ahead and take a forced breath in, like as much as they can get, and see. And if that happens, that's your spinobasilar. Yes.
In the first week, we learned respiratory adjustments, and then you screen for on the inhale or on the exhale is what's going to help. How do you differentiate that between it being a positive for a cranial signal?
It's the same. It's the same. If you use breath in or breath out to test to see if it affects muscle function, weak muscle goes strong. Common way we do that. That's a cranial. You screen for cranial. Now it could also be sacral too. It could also be pelvic. It could also be diaphragm. But just in this particular arena, we'll just refer to it as cranial sacral.
But then there were times that we would, just clarify. So
So for a cranial, if you have a weak muscle and you take a breath in or breath out and hold it and it changes the muscle, then that's an indicator for a cranial. When you're doing a respiratory manipulation, you've already found the direction that the spine is, and you're using the breath to indicate how to correct it, which way to correct it.
Right.
So you're almost like first step for screening for cranial versus the third step for fixing it. Does that make sense?
Yeah.
Okay.
Yeah, that's good. Cranial is going to be more of a global response. Usually when there's a cranial sacral dural cord problem, there'll be a bunch of muscles weak, and they'll all respond. Most of them will respond to the breath. So we're dealing with subluxation. When we're doing respiratory corrections, like on for subluxation, which I think we learned in session 1, then by then you've already cleared. You got to clear cranials pretty early on. That's why they're really. That's what we teach in the first couple sessions. If their cranials are off, you're going to be chasing your tail. All these other tests and these different flows, these little flow chart things will throw it off. So it's really important that it's one of the most important things to screen for first is cranial, I think. And then of course all the other things, switching and gait, and you can clear for all kinds. You can test and screen for all kinds of things, but this one really overrides a lot of them in importance. That's a good question, and that was good. The way Dr. Whitney explained it is absolutely right. I wasn't sure what you were asking about that because I didn't think we did cranial session 1, but we did respiratory corrections. Now, here's the muscles we're going to learn. Oh, we learned last session. Okay, any questions on these? Everybody remember how to test these? We'll review all these at some point today. We talked about dural cord, gait, neurological disorganization, cranial, CAT2, cranial, kind of touched on motions a little bit. Yeah, for switching, CSF, remember we make about half a liter a day. Cerebral spinal fluid is constantly being produced. Okay, so I was going through the, and I felt bad because I keep skipping over the cutaneous receptors. And, they're on all the slides. It's like, what's that? Well, never mind. Well, I threw some slides together so you can get familiar with these. These are fun to play with. They're not a high priority reflex to go after until you've cleared a lot of the big stuff. A lot of times these will be, and they're all on the head, and a lot of times they'll be in areas where there's been trauma, or there's been a chronic cranial jamming of some kind, or scar, from a surgery or whatever. In Dr. Walter talks about this often will be associated with a hypertonic muscle. A lot of times you can reveal muscles that are abnormally hypertonic. Now, Dr. Wally Schmidt, with his IRT protocols, which we're going to learn in next session, most of these will clear with IRT. These reflexes were discovered decades ago, and there's a certain way to treat them, which we'll learn. But honestly, most of them will respond, which is much simpler, and you guys have learned that. Anyway, so there are these certain zones. Most of them are lines. Some are circles. Some are like kind of areas, but they're associated with a certain muscle, and of course then associated with a certain organ and gland associated with that muscle. They will therapy localize. Often there are areas across the suture. Often there are areas where often they involve the meridian, because bunch of the meridians come up through the head, so everyone knows a scar or injury can disrupt it. This, a lot of times that's what you find with these. I put these in your slides. You can print these off. These are in Walter. These are all the points. And the way you find them is if you have a weak muscle, say a weak psoas, you've done all the stuff, you've cleared just pelvis, you've just done all the stuff, and then it's maybe it turns on, then you have the patient walk around and it goes weak again. So there's something you're missing. That's when you want to go to things like this. Grab your chart and like, oh, let's have him or her TL the line for psoas. Where psoas is. I think it's never worked. I didn't know all these for diplomate, but I don't really use them very often. Anyway, find it somewhere. There it is, right there above the ear. Yeah. So you have them just TL to that, and muscle turns on, and then what you use, you TL, and you look for a change when you traction it. So a lot of times it will go, the strong muscle will go weak if you TL it, and then if you traction it, it turns on again. And that, of course, is the way you treat these just like you would a crane. So anyway, so just to kind of fill that in, when we go through the different muscles, and at the end it goes cranial stress receptor, cutaneous receptor, you'll have something to do. But these are something you do after you've fixed all the big things. Anyway, I found anybody here familiar with Dr. Mark Ellis? Of course you are, yeah. Yeah. He's wonderful. His stuff is fantastic. I can't get enough of his stuff. He's just, and he's really a cool guy. He's a lot of fun to talk with. I stole one of his slides. That's why I put his name out here. So he's a fantastic resource. He's a neurologist. He's a chiropractic neurologist. He's not an AK diplomate, but I think he's close. But he teaches kind of neurology, all kinds of really interesting neurologically based protocols. But this slide was in last summer's presentation. And I don't know if you can see this very good, but it's just kind of a way to kind of organize our thinking sometimes with what are we really dealing with, especially with muscle testing. There's so many different things that will affect the muscle test. You have to really be aware of all of these things. The sound of your voice can cause a muscle patient to weaken. How you touch them, on and on it goes. But are they dehydrated? Are they a little dizzy, or too much caffeine? Any number of these things can affect muscle tests, and so that's why it's so important when we're setting up to test a muscle, that we're really conscious about our hand placement, our testing hand, stabilizing hand. We're really aware of what the patient's experiencing. Are they fidgeting? Are they in pain? Sometimes I'll set somebody up seated and I'll start testing them. And maybe they tested pretty good standing, but as soon as I sit them on the table and start testing everything, well, clearly I've changed the parameters of the test dramatically. And if you sit someone from standing, all of a sudden now you're loading the pelvis. You're loading the pelvis, and if there's problems there, you're going to be throwing a whole bunch of new nociception into the central nervous system, cause things to be things that aren't pouring in when you're standing. That's why it's, I think, very important that when you test someone, supine, which is the most convenient way of how we do most of our tests, but we don't live standing and seated and bent over and doing all kinds of stuff. So that's the least stressed position that the human body can be in. So we might get everything balanced and turned on in that position, but as soon as they stand up and walk around, some other thing moves. So be aware of that. So we're going to talk about category 1, which is the three pelvic categories that we use in AHA. There's category 1, category 2, which you learned last session, and category 3. Category 1, and they're not a degree of severity. They're just different. Not like hurricanes or anything. Category 1, and we talked about when we were learning, I think in session 1, I'm talking about posture. When you look at the patient from behind, they have a lateral sway with their pelvis off the plumb line. That's a category 2 side. If the head and everything else on the plumb line, but they're sort of turned like that, that's a category 1. If they're standing like this and the plumb line comes down and they're like this off the plumb line, that's category 3. Take that. That is like, you see that posture.
Can you do that again?
What's that?
Can you go through that again?
Yes. So, well, everybody stand up. Everybody stand up and do it. Do what I do. So first we'll go 1, 2, 3. We're going to learn 1 here. So 1, you just basically, your feet are on the ground and you're just going to turn your body and stand there. That's category 1. The plumb line will still pretty much run, straight through. So the back of the head, the crease, and the feet. That's category 1. Okay, standing straight and let your pelvis side slip to one side, and your head and feet are still on the plumb line. That's category 2. That's like PIAS, UMS, and LLL. Remember from last session? You can do the other side too. Actually, I think I might have it. So that's category 2. Category 3, you're standing and your whole torso is just going to tip to one side. That's category 3. Now, a lot of times you'll be tipped to one side and maybe forward, or sometimes tipped to one side and back. Because that involves disc. Category 3 will involve a disc. Act like a disc. A lot of times the disc is inflamed. But, so temporal bulge is a cranial that kind of goes along with category 1. Temporal bulge and parietal descent, they're a pairing. On one side, we're going to have a bulge. On the other side, we're going to have where it kind of collapses. Atlanto-occipital counter torque, it's an old-fashioned thing. It's kind of a way of looking at the occiput. It's just another way to kind of clear the upper cervicals. Phylum terminal coccyx lift. That's another kind of old SOT technique. Learn that. We're going to learn the middle and lower trapezius, which has a lot to do with, it's on the spleen meridian. It has a lot to do with immune function. Serratus anterior, which is the muscle that started the whole thing. Dr. Goodhart corrected a dysfunctional serratus on his first AK patient many decades ago, and that's how the whole thing got started. Neck extensors, we've already learned neck flexors, session 1. Neck extensors. Adductors. And of course, the pec, we've learned the pec major, sternal, and clavicular. We're going to learn the pec minor. It has a lot to do with lymphatic drainage through popliteus. We're learning these muscles are clumped together in session 3 for several reasons. One of which is we're going to learn fixations. Spinal fixations will often display with a bilateral muscle weakness, specific bilateral muscle weakness. That's, we'll see bilateral popliteus weakness is a mid-cervical fixation. Teres major is going to be a thoracic, on and on it goes. Lower trap is going to be a thoracolumbar fixation. Bilateral psoas is going to be an occipital fixation. Bilateral glute max is going to be an upper cervical fixation. These are really, clinically, these are really, that's a really helpful technique. Because you're all learning about fixation. You learn how to adjust fixations, right? I'm sure they teach probably motion palpation. So this will allow you to test to see how the fixation is affected. Not just is it stuck, is it stuck, and is it affecting everything downstream? And then after you correct it, you can go back and retest it. You'll know you got it, and you didn't get it all. So that's that. I learned fixations in, I don't know, first year chiropractic, but I never really had a way to thoroughly know if I was adjusting them properly until I started using it. Completely transformed my approach to adjusting.
If they have multiple that are bilaterally weak, they just have one. If there are multiple groups of muscles that are bilaterally weak, there be more fixation than that.
There could be more than, yeah, it could be more than one fixation. Also, it could be something even more central. And it could be a lot of times when you have cranial issues, all kinds of stuff. And that's, so that kind of gets into more advanced stuff. One of the things I do on people all the time, especially when I first start working with them, is I'll make sure that their eyes are always in a certain state of open. Like if they keep closing their eyes when I test them, then I will start testing with eyes open and closed, one eye, other eye, because they got stuff going on. And a lot of times their cerebellum is kind of wacky. And a lot of times these are a lot of times the people who don't sleep. And a lot of times I'll have to, if their eye movement keeps throwing all the tests off, I'll just have to close their eyes and keep them closed so I can get some traction. But yeah, that's a good question. But a lot, you're going to find these all the time. Just like category 2, you're going to find, if you look for it, you'll find it all. Cranials, if you look for them, you'll find it all the time. This was in the slide. I didn't put this in, but I thought it was kind of cute. I had no idea what he was talking about. It's kind of cool. You guys question everything, right? So, repeated muscle activation. One of the things that we find a lot is when we're testing muscles and they test strong or weak, but then it tests strong, but as we're going through our thing, it starts weakening, and we start thinking it's because of the other things we're testing, but a lot of times the muscle is fatiguing out. And this is, I think, overlooked in AK. Dr. Goodhart, this was one of his, years ago, he realized that if a patient can't actively on their own contract the muscle 10 times, if they can't do that without it weakening, then there's a problem. And you have to quit using that muscle, and it might be 5 factors, or it might be the muscle itself, but you have to fix that muscle. And he called it repeated muscle activation, patient-induced. So how do you know if you have this? How do you know if you don't? But an indication could be, and we're going to, the next thing we're going to talk about is action injuries. An indication could be if there's a bunch of muscles weak around a certain joint, but one of them strong, that often is your RMP sub I. We're going to, when we get to the next section, when we get to compaction, then I'll take somebody out and see if we can demonstrate. So anyway, you have them contract the muscle, regardless of what it is. If it's a glute med, have them contract it 10 times. Kind of slow. You want to really deplete that muscle. The idea is you're trying to reveal. Dr. Goodhart felt it was a choline deficiency. There was a lack of optimal acetylcholine metabolism from nutritional. But he also found it was often had to do with cervicals. You want to check that first. Choline, vitamin E. I love phosphatidylcholine. I just, that seems, sometimes I use that on patients just because it tests, and I'm not always sure, but it's of course very important for liver function and gallbladder drainage, but it's really important for the production of acetylcholine. So you check the muscle for RMAP sub I, and Dr. Francis always says RMPA sub I, or RMAP sub I, small I. You have a strong muscle that goes weak with 10 contractions. Check for spinal nerve supply, nerve attaches oxygen to the sacrum. Check O9. Usually it will respond to O9, more often than not. So that brings us into compaction injuries. So this is a good time to review from last session. If you have a typical kind of injuries, like a straightforward muscle strain and the muscle's weak because that muscle will usually respond, especially initially, to spindle, to GTO, and to O&I. One or the other or several. That's the primary muscle in the triad strain. Shearing injuries. These are the different, like we learned these treatments, right? We learned origin insertion, we learned Golgi tendon, neuromuscular spindle, and now this is going to add another thing that you can test the muscle. AP sub I. Okay, so here's a comparison of the two kinds of injuries. There is usually, but not always, a history of trauma. Usually there's a history of trauma. Sometimes the trauma was way back and it's something that's just never gotten resolved, but there's usually almost always a history of trauma. So the primary there'll be one primary weak muscle, and it will respond to spindle, O&I, or GTO. The antagonist will be often hypertonic. It'll be tight and painful a lot of times. That's the muscle that brought the patient in. And it will respond to fascial flush and proprioceptive neural facilitation, where you hold and then you release. That will help flush and get the fascial congestion out there. The synergists will often be strong in the clear, but they will weaken after a 5 to 6 second contraction, isometric. So the fascial flush muscle will weaken. It'll be strong in the clear. Give it a stretch, say it's the lat, and it will go weak. A strain counterstrain synergist, you would say, for example, say it's the lat, that's the primary weak muscle, and then of course the delt is going to be antagonistic to that. The delt is now delt's not a good example. The pec, a lot of times the pec is hypertonic. So you test it strong in the clear, you give it a stretch, and that's an actual flush muscle. This is review. If it was a strain counter strain muscle, you would have to do a 5 to 6 second contraction, and then retest it, and it would be strong in the clear, isometric contraction, retest. That's a strain counter strain muscle. So that's the triad of strain sprain. In comparison, compaction also there's a history of trauma. And compaction is just what it says. It's like you fall and you jam a shoulder. So common. I find it a lot in hips, ankles, and shoulders, and wrists, but especially shoulders and hips. The talus. A lot of times you find it in the all the muscles across the joint will be weak. So if you have compaction in the shoulder, everything's weak except for one. And maybe it's the delt, maybe it's one of the pecs, but one muscle will be strong in the clear. That's the muscle you want to test for RMAP. 10 contractions, then you retest it, it will go weak. And it usually will respond to origin assertion. That's the first line. Go to the origin assertion, treat it under circular massage, pushing the tendon fibers into the periosteum, making sure they kind of get a good set. That's the difference. Two kinds of post-traumatic injury. Anybody failed or done something? Anybody, a runner, sprinter, weightlifting, running?
Yeah, with the dog.
Do you have any pain?
I did have pain in
What did-
my weight lift.
Okay. Let me check you. What I'm looking for is, so you don't really have any pain right now, but except for the knee was an issue. Go ahead and lay on your back. And select. Now, guys, remember, I'm just gonna. So, what am I testing? Sing it out. Quad of which one? Rectus femoris, right? Everybody in agreement? So, now which muscles am I testing? Quads. This is quads as a group, right? And this is rectus femoris. And a lot of times, because remember, rectus crosses both the hip, so it's a different situation. So, okay, so that right there. What am I testing? Everyone in agreement. So right? Now what am I testing? Iliacus. Right? Okay. All right. Now, what am I testing? I might be getting hard of hearing.
No, we're quiet. Everyone's quiet.
Yeah. Both talkers. So what am I testing? Piriformis. Feel free to sing it out. And if you say the wrong thing, I won't ridicule you. I'll just say, no, that's incorrect. Piriformis. Okay, what else while we're here? Okay, so what am I testing? Smooth beat, okay. Now, what am I testing? TFL, right. All right, this is a test, I think, push down towards the floor. What am I testing there? Glue max. It's a cheap test for glue max. The best test is a pro, but it's a cheap, quick test. Okay, here's a cheap test for that. For what? Adductors. And we're going to learn the cheap test. That was good. This was not. So this doesn't act like a compaction because there is one weak muscle, but there isn't like a bunch. So I don't think you have. You might have it, but not. It's not. It's not an obvious issue for you.
Were you looking for?
Well, I'm sure it's going to be easier to find.
That's like.
You know, you had a. What was it? You had something.
Oh, yeah, I did have compaction. It fell.
Shoulder. Yeah.
Yeah. If you as someone else.
Yeah. So you lift weights, heavy weights.
Yeah.
What's your what lifts? Do like classic lifts or leans and all that? Are you having it? Had surgery before. That one. Okay. So laying back. So compaction, just just the way it sounds, like you're compacting. You think about the forces that go through a joint, profound, especially like a hip joint or great bearing joint. The body is designed to take forces and disperse them. That's how it protects itself. And when we have any kind of failure or suboptimal function of that system, forces instead of getting dispersed get concentrated. Then that causes pretty soon you've got damage. And then so it's I think what we're where we can really serve our patients is to find where this dysfunction is before it has a chance to do real damage. So I'm just going to start with some basic push out. I'm looking for, that's nice and deep, good. Push out. And that's nice and deep. Okay. So, there. And that's, well, there. So I'm testing muscles that have to do, no. Yeah. So we got, so far, yeah. Okay, push up and out. TFL. The adductors. Okay, let's try the hamstrings. Remember these? Push back. Now the hamstrings are strong. So far that's it. Right? Push down. Now, when you find that, we're looking for compaction, or we're considering that as a possibility. When you see that, the way to determine if it's compaction is you give the joint a contraction. Just take, and I'll grab above the talus, and I'll just give it a little pull. Yeah. I mean, actually release it. So you do that, and then right after that, you start testing again. And look at the difference. That's a perfect example. Push in. That turned on. Push. That turned on. Everything turned on. Isn't that cool? So that's compaction. Now, what about the RMA P sub I? Well, the one group, we didn't test individually, but the one group that was strong was the hamstrings. Strong medial, strong lateral. So let's have you stand, and I'm going to have you, I want you to just fully contract that hamstring. Not like they have 10 times stability. Nice and slow, make that muscle, make it work. Squeeze a little bit at the end. Of course, you could do this patient from. Yeah. Hold that right there. Ah, beautiful. Look at that. Now, if we left it alone, didn't do anything, it would probably turn back on again. But, so we're going to test it for what technique? Oh, what on? Probably easier. Do we have paper or something?
I guess on the table.
These guys here. So, this side, right? And we didn't, I mean, she could have it both sides. We just didn't. She had a weak glute on that side too, so just for demonstration. So, push. See, it's turned back on again already. So, I'm just going to go, because it's hard for her to TL, I'm going to go right to the insertion points. I'm just going to kind of stimulate them a little bit. Yeah, and so, and then I'm going to go up to the origin, okay? And I'm usually going to, now see, that doesn't show, but we go in here. And this is basically like a challenge. Yeah. So, let it relax. So when you do an O and I, take your time, trace your, like with this, I trace the tendon down to where I find where it ties into the bone. And I want to be pretty specific. Is that tender?
Yeah.
Is that tender? More so? So, how about here? Not so much?
Okay.
Here?
Yeah.
So I'm just going to go in, I'm just doing a little circular massage, nice and, is that tolerable? And you'll feel sometimes there'll be kind of a puffiness-ish, and you'll feel it dissipate. And sometimes you don't feel much, you just have to be tested. Now the other side, I'm going to do both sides. They both tested. Is that okay? I'm right on the back of her, what should we call it there, fibular head. What's that?
That's sad.
Well, no, this is good because, what's that? Yeah. That pressure okay? I don't know, 30 seconds, 20 seconds, or until you feel it dissipate. So let's see here. Push. I'll go back to the original thing. I did a little stimulation on the eye. That doesn't show, so go ahead and lay on your back for me. So push out. That's still strong. It may have reset it. And we did do the little pull. And I didn't intend, I just did the traction to do the test. I didn't really intend to adjust it.
Is the idea that there would have been, if that would have corrected it, like stagnation at the insertion? What is it that's wrong?
So the fibers of the tendon come along, and then here's the fibers of the periosteum. And this is how they attach. There's a broad area depending on the muscle and where it's at. So you've got this going on. It's like fibers of a rope. And what happens is, and of course, there's receptors that are rather primitive receptors that sense if there's disruption there, it'll produce nociception. That is what's causing the muscle to go weak. But irritation, too much pull, trauma can cause a loosening of those fibers. And it's not like a rupture, but it's like a micro avulsion. And what you do is you just physically get in there and you push. I liken it to if you're going to glue the end of a rope to a board, and you get the goop on there and you get it there, and the glue's starting to set, but it's starting to come loose. What do? You go and you just push it down in, make sure the glue really gets into the fibers. Then maybe you set a weight on it or something. That's kind of the way I think about how it is. And what you're doing is you're resetting something. Now, a lot of times it's an older injury and maybe the fibers were disrupted and then they kind of healed, but they're still not right. Like the receptors are still picking up aberrant signals. So the brain still thinks it's kind of injured. Maybe the tissue itself isn't hit pretty well. So what we're doing is we're kind of resetting those receptors. I have a better explanation.
Let's say I have an old injury and know exactly what to do. I can just go ahead and
Sure.
try against the ball.
Oh yeah.
Going
Yeah.
to the hole.
Absolutely. These techniques predate AK. They're basic physical medicine techniques. Been around forever. But AK, we just have a way to test for it. So absolutely.
Thank you. The glue and the rope. And
Glue and the
weight,
rope.
That was a great
Okay, good.
way to get it.
Good. Oh, yes. So did we have a bunch of stuff we can bring? Everything's good. TFL. That's even good. Now, hold there, pull back. Good. Now do the contraction thing. It's like your slow motion. It's like dream running. Yeah. Relax that right knee. You did? Goodness, I didn't know that. We're testing you and beating you up. Okay. So, there again. So, that's good. Yeah. You're as good. I mean, hold on. Let me check the other side because if the other side, because sometimes with weightlifting you can get some compaction, obviously, in both sides. See, that one's. I'm not going to test. Well, actually, this was strong. That was strong before. There. Yeah, I don't think you have it on this side. No, you do have a weak glute knee, but that's something else. Put one hand on your right hand side. What did she TL in for? It is. Category 2.
Oh, the good one, I was leaning.
I didn't even think about that. I just thought it's. Yeah, so she's got a category 2 also. And we can screen for trainings. Breathe in. Hold your breath. Maybe not so much. Half breath in. So not with the mouth, with the nose. Full breath in. Yeah, so she has a mosquito base. That would be the cruciate. Mosquito basement would be that. Oh. So hang on to that. She got a cat 2 and a mosquito basement. But we cleared that compaction on the hip. Yes, you did. Thank you.
Balancing and up, would your mind go to check?
if they're dizzy, I mean, if they're
No, like if you
unstable.
have them do like the test like that.
Oh, I would put them by the wall. You know, I mean, she's a young, fit person. Works out.
Or would you go to the community? They can't like eyes.
Not necessarily. I'd probably check for ocular lock first, and then yeah. Yeah, it depends. Yeah, depends. Like this is kind of an isolated protocol. There would be a lot of things I would consider as on my way to that, and on my way past that. But I just wanted you guys to see the compaction. And that was a good example of it. Really. Now the other side doesn't have it, just the left side. But those that you'll find those all the time, and they. If you don't clear the, I mean, if you keep, usually the person has pain in the area. You're trying to fix their hip or their shoulder, whatever it is. But if all the muscles are weak, you don't, if they're all weak or all but one, that's when you think compaction. Otherwise, you'll be chasing each weak muscle down. Chase each one down. So it's a huge, yeah. That was a good example. So we'll see if we can. I do want you guys to workshop this at some point. It's so I want to go over the strains, the triad strain again really quick. So I want to make sure everyone is up to the same speed on this because these two things are crucial. And you'll need to know this for your test. You'll need to know triad of strain, O and I, all that. You need to know posture. Know your basic postural stuff. So does anybody have an injury, like a strain of some kind that's fresh? Or not even that fresh? Everybody's got something, but nothing glaring. Guys, you. Which knee? Right? How'd you mess it up? Well, don't then just make something up. Squat. How long ago? A couple months ago. So that's interesting. Have you had any imaging? So the knee. So that might work. Lay on your back. So we have a history of trauma for sure, right? What else do we need? We need a primary weak muscle or two. Shouldn't be too hard. So where would I start? If I wanted to, now we've learned the quads and the hamstrings. We haven't learned the popliteus. We're going to learn that this weekend. Absolutely. We learned that, that's right. Last session we learned sartorius and gracilis. So let's not start with those two though. I'm going to look at this side. So I like to start with the rectus because I don't know, I just do. I like to start with the rectus. That's pretty good. Now, we're going to do the other quads. Any pain? So sometimes when there's a history of push there this way, okay.
It's like
In this position. Okay, so in this position, bend your knee. Not as much. This position more. Now bend it. Okay, so there's, yeah, it's not a happy. Now, let's have you, this is what we're going to learn in this session. This is popliteus. It's just like you're going to test hamstrings. or you're going to test, like we're going to learn eventually, a way to test the gas drop. But it'd be just like a hamstring setup, heel on the table, and you rotate the tibia medially. Because what you're wanting to do, the popliteus contracts. As it contracts, it rotates the tibia medially, internally, relative to the femur. That's what his job is. And so you're offering it its full contraction position. And then you stabilize the outside of your ankle, and you try to turn this tibia. Yeah, obviously, you end up testing some ankle. See, that's weak. That's weak. So that is a problem. So let's try this one. Yeah, that one's fine. So you guys have all had a fair amount of anatomy and biomechanics by now. Remember the screw hole mechanism in the knee? Anybody not?
You don't learn it with that verbiage.
That's just the standard ortho, old speak. Ortho speak.
No one knows what you're talking about.
Yeah. So, okay, so as, what's that?
I said no one knows what you're talking about, so you can explain it.
Interesting, okay. Okay. So the knee is, there's three motions going on at the knee. There's the rotation, there is the gliding, and there's an internal rotation of the tibia relative to the femur as the knee flexes. So if we go from here to here, the tibia internally rotates, the medial tibial plateau translates back. So it's like this, there's those motions. And then there's, of course, the hinging motion. The axis is what's above the actual glutes. So the muscle that manages that, that's called, so when we go into full extension, the tibia locks externally. That's what they call the screw hole mechanism. So it makes the knee very stable at full extension. And the popliteus is actually in a lengthened or relaxed position when the knee is locked. But what the popliteus does is it takes the knee out of the screw hole position as you bend. That's what it does. So and you have one that's not firing. Now, if you had both of them, we'd think. So I go right into the popliteus. Tender. The tender. Kind of. How about here? There. So right in the middle of the popliteus. Of course, there's a big bursa there too. Sometimes that can be. So I just, by pushing in there, yeah, that is not a happy. So that's not a good example of triadic sprain. Jump off script for just a second here. I want you to touch right. Feel the difference? Yeah, okay, so save that.
Okay.
Okay. That's the Chapman reflex for the gallbladder and the liver. And on the fifth intercostal on the right of the So that could be something, there could be a reason why it's not healing. You know, why it's not resolving. That could be underlying. Anybody else hurt their, got a sore or something or other? Nothing. You guys are in great shape. You? Shoulder, hip, back. That might be too complicated, but it would be fun to tackle. But what about an ankle? Anybody got an ankle, like a chronically unstable ankle? Please bring your somebody bring up their chronically finicky unstable ankle.
Mine clicks a lot.
What's that?
Mine clicks a lot.
It clicks a lot.
Yeah, but I don't have any pain in it.
Have you injured it in the past?
Some sprains.
Which ankle? Right. So we're gonna just go straight. I mean, I would, of course, do a whole bunch of other stuff, but let's just see what we. So I'm gonna, so where does it hurt? Here?
Yeah.
Okay. Okay. So these are, we're gonna do ankle and leg, I think, it's a couple of sessions from now, but here's what I'm just gonna run through this. Hold that right there. This is the peroneus longus and brevis. Oh. And that's not the strongest. Now go chew. Yeah, relax your jaw. Toes down. Hold that right there. This is peroneus tertius. That one's good. Up at the end, keep the toes curled. This is tib anterior. Ah, not so good. And down and in. This is tib posterior. So yeah, so she's got, actually that's compaction. That's probably a compaction. But the one that was strong was peroneus. And what's the muscle that's always injured with an inversion sprain? Peroneus. It's the muscle that's job is to keep you from overly inverting. So I'm going to have you do 10 contractions. Okay, just out, allowing to activate that peroneus. So go down and out and up and down and out and up. Good.
They changed the name of like the peroneus longus.
Who did?
Anatomy, they learned it early. I learned it peroneus, so that's what I
How
call
can
it
you
too.
just change? Thank you. Who did? Fibularis. Sounds like something
I
you
was
would guess.
thinking, I just don't know.
Okay, now. hold it. Okay, so that's perfect. She weakens after 10 or 13 contractions. So she doesn't have the trilogy so much. She's got compaction. So what I'm going to do with these up, I'm going to see what happens when I traction. And now when I was tractioning the hip, my thumbs were above the talus. I wasn't involved in the talus. Now I've got a thumb right on the front of the talus. I support it with my other thumb, and I just give that a little traction, and then bring this up and in. Hold there, and that turns on down and in, down and down. Hold. That turns on. You can feel the difference, right? This one, of course, was strong. The clear and weak into the. So that. So I'm going to do O and I, the peroneus, fibularis. Is it fibularis longus and brevis?
I think they did it because like tib anterior and posterior, right, is along the tibia, and this is on the fibular side. That must have changed it.
Proverbial vein.
Well, yeah, I don't know. I learned
Wherever
that
they are.
peroneus, so I forget about it too. So that's what I call it.
It's like I hear this every day. They say you should do this and that. And I'm like,
Yeah, I don't know how you go back
Who are
through
they?
and change anatomy.
I know.
From decades ago, but they didn't send an email about it.
what's that?
So they didn't send out like an email.
I
about
didn't
it.
get the memo for sure. I have heard that though, somewhere along the way. Maybe it was here. Maybe somebody. Because I have.
It is recent change.
Okay. So I'm just doing the whole muscle here, but okay. Now let's have you go down and in. She's still strong. And up and out, and down and down. See, all I did was the O and I on the peroneus. All I did, and I did a little traction, but I didn't really adjust it. I would. Okay, if we adjust that.
Yeah.
So the talus adjustment is basically just like the challenge. I just take it a little bit there. Sometimes I'll come up like this, and I'll put my hand over the talus this way, and I'll just kind of gently rock it. as I push up on the tibia. That's a really nice adjustment for especially chronic ankle people. And sometimes you'll get a little clump, it will reset in there, usually not, but sometimes it will. Yes, thank you. So 2 compactions. Most of the time the shearing injuries are pretty common, but I guess not in this group today. Let's take a, let's see where we're at. I want everybody to get a chance to stand up. Okay, just kind of reiterate. The muscle will, with compaction injury, all the muscles around the joint, that's the first 2, all the muscles around the joint will test weak. Except 1, and maybe 2, but usually 1. Like 2 of her ankle were, 1 was definitely strong, the other one was not too bad, but the rest were all weak. Anyway, O and I is your go-to. This is usually you fixed a bunch of stuff and then the thing comes back. And that's when you really start thinking of O and I. And, but traction of the joint will be your giveaway. Those muscles are all weak, and you traction the joint and they turn on. If they don't, then you got something else. So Dr. Wally Smith talked about pantothenic acid. It's supposed to be in wheat germ oil. So that's the classic. There's probably a lot of things you could look at, but that's something you want to know. Yes.
You said if it comes back, then you'll go to O and I. Will it come back right away, or is it the next session you're retesting them?
You never know. They might come back. That's why it's always nice to have them get up and move around. I don't really have a very big office, so like I don't have a hallway, but I'll have them do things like this and jump up and down and try to stress it, because it might go out by the time they get to the car in the parking lot. But a lot of times it's, you think about it, there's a pattern of aberrant force management. That's the kind of the big picture. And we're trying to eliminate those patterns, and use those patterns were established because the body does whatever it has to do when there's nociception. And it doesn't care if we walk around like this. Our subconscious doesn't care as long as we're up.
So, would it be wrong to say that like the strong muscle before action compensating, and that's why
Yes.
it goes weak after?
Yeah, that would be kind of that's kind of the working theory around that. That it's somehow the brain is able to get the signal through to the hamstrings, you in particular, and but then of course the tone gets set. The tone gets set too high in that muscle, and then when it will cause inhibition to the other muscles. So it's sort of a perpetuating problem. Anyway, so wheat germ oil, choline, riboflavin, your standard acetylcholine nutritional components. Treat with O and I, wheat germ oil, choline. I don't know. I think this is one of Dr. Kim's. I'm not sure melatonin. Seen that? It's not in Walter, but anyway, always think about underlying when there's chronic underlying inflammatory activity in the body. Always think about chronic food intolerances or chronic bad proteins floating around and causing trouble. That's why with your popliteus, there could be something going on. So anyway, this is kind of a list of things. Some of these we've started to talk about. We learned plus, upper gate. TMJ we'll get into real deep. We're learning about dural torque, DTRs. I'm going to try to get to the end. And these are all just ways to dig deeper. When the most obvious treatments either fail or if they work, but the problem keeps coming back. Recidivism, right? So all of these things can be underlined and undermining your treatment attempts. So this is just one particular sort of way to start organizing your treatment approach. Things don't have to be organized in this way, but this is, for a long time, I was doing this on all my new patients. And then I kind of get into other things. This is bad. Anyway, the top there, ocular lock, we learned last session. You can screen for emotions. There's a whole host of different things like that. Screen for gait. A lot of times you have to do posture and then go right into gait while they're standing. Plus, Cat 1, Cat 2, screen for all that. ICV, we're going to learn that this session. That's a big ticket. That's a big ticket. Then, of course, cranial. That's just one way to kind of like approach if you're going to like go in and try to zero in on what you want to do. Anyway, let's take a short break here, and then maybe we can do some stuff. Cool. Thanks for bringing that.
That's fair. Yeah.
Well, you're fine.
Yeah. Yeah.
I just
Can't believe I use it.
well, part of me too is like, I'm like, I don't remember something I don't have. I literally so like some stuff I'm like, oh, I forget what that is. Or, like I don't know the long ones. But I love like just like patterns and like okay, what were it? It's just like some random muscles I don't.
I've got that. I've got
That's the I don't think I ever this. Yeah, that's probably
no, I think that's probably hear that.
or like the clock. I don't know if like clocks.
Oh, yeah.
How are you? So good.
In fact, I wish they had.
I know they don't.
That's the only thing I would like to see.
Yeah, so that one I'm like, I know the time. It's not even. Never mind, maybe you put it. No, we're great. We're walking in sunshine. Yeah.
Right.
So. Oh.
I used to, because I've done yoga for years, and I used to get up early enough to do exercise. So that's how I remember. So I remember, and I remember, because I remember the flow. That way I can see what time.
Oh, this is human order, right? So this is called liver. So this is liver, lung.
No. Oh yeah. I just don't want to forget. Yeah. I will forget. Same. Same. I'm Which one? Okay. This is the correct amount. You're doing the previous student. Okay. Yeah. Charge you. Thank you. Charge. That's loud. Also, the little printer receipt. Do you want a receipt? Good. Thank you. You don't want it at all? I could text it to you. Okay. Thank you. I don't know. Like I caught you doing this so bad. Let me see. How you doing? Just how you doing? I'm good. Oh, I'm definitely gonna do the second part. I just was nervous about it. Like the second interview. Yeah. Oh, I'm definitely good. It made no sense. I was just like, yeah, this is like hard. Yeah. Like, I mean, it makes sense that you could find someone AP. But there's so many like MDs that don't practice that. Like AP, so I thought they were right. And then I was like, oh,
It does make sense.
yeah.
Just have like more tools.
Yeah. There should be water with fire. I was like, I'm very regular.
You know, the good thing would be though if you got hired, which I don't feel like you wouldn't, but it's someone you know.
Oh
And you
no.
know that you
I
would.
texted Elisa.
So it's like,
we would be work together. I was like,
you know, that would be like, you don't have to worry about like, I don't know, your
vibes,
yeah.
like, are they giving me with it? Like, no, honestly, with them, like, it's really intimidating because I feel like they're both incredible practitioners. So, I'm looking at it as like, God gives me the opportunity to work with them. Like, I'm excited. But then I mean, like, I could grow into, like, you know, catch up to that. They're both like, he does really cool work, and she's just so into it.
Yeah.
And the, like, work and like, so yeah, I'm like,
I know. I like worry because it's like, I know I want to give them how is like a very different thing, and I'm just like,
and I feel like so that's the interesting thing. If you have the opportunity to work with a doctor that does AP, like, that's good. But all the doctors that I like worked with,
oh, you want to go?
like a little 2 minute outside. That's
Yeah, no, I can take this.
But all the doctors like they all except for those last two who had garden all the but maybe it's because the parents
So, that's what you. That's something you do. Maybe go.
Yes. That's why I picked one way to remember.
That's why I have it on the wall.
One of the hardest things when I did my one of the hardest things was you didn't know what to do. And you had to know how to. That's why I think I remember because Exactly, that's what. And yeah, that's, yeah. It's still, it messes with your mind when you try to match it up. But there is a line of reason to that. And I find it, I just stumbled and just those things. And then I kept thinking, well, there's more to it. What happens is, sometimes everybody will be weak, especially. And it's like all the fire belly muscles. Everything fire. And except for and so one alarm, I'll either use one place. One not me. And then I was just find that it could be any of these, usually almost always, but not necessarily. Like it could be guardian transformer, small intestine, could be the school, right? And one of those, like everything, it's kind of like, I think that's, and I don't need to know what this is. It's like a shortcut. It's quick really without chasing down a bunch of things. It's kind of like ocular lock. The only thing I can it's something more central. That's the not sure. That's why I never really spent paper because I thought it was a lot more. Somebody sure, but it's sure it's actually. Oh, you know, that's this. But they could be right. I mean, I would learn something. What is it that's common to? And honestly, it's probably something to do with sympathetic parasympathetic. You know, they could convert, they could be sympathetic, sympathetic dominance, where they kind of flip back into their sympathetic dominance, and their body is just tired and sluggish. And that's probably because I mean the sympathetic parasympathetic, that's all part of the nervous system. Right. Anyway, if you ever run across that,
Okay,
it's just exactly what You know, just there'll usually be one muscle that is weak. Are you cold?
Yeah, and I didn't bring a sweater. I brought my sister back.
Wow.
Wow. I'm sorry.
You definitely live in the right part of the country then.
Yeah. This is so true. I grew up in New Jersey too, and I was not cold there. I don't remember being cold there. So I don't think I run cold. I just like being warm. Does that make any sense?
Yeah, nobody wants to be cold.
Next time for questions.
Yeah.
So for the single, I remember the last year I don't know, a little bit. Yeah, what's your preference? You're cold.
Cool.
What's the difference between
Did he ask you a question?
You're gonna.
Oh, I like cold weather.
The test usually, if hope is the reason that
I'll still fucking sweat.
Did I show you guys this?
And sometimes the muscles will just be weak because it got. You see somebody over in the gym.
You
A
what?
lot of times that muscle will fix you. It's just they just. They didn't set up for real.
No.
All those guys do that.
He was so
Set
upset.
it back up.
Because you wanted to go sweet. How often is it?
This is going to be
Not very well.
I got him to be
Often when I'm feeling, especially with stressed. But as far as like long term chronic, it's just adhesive. The nicest thing about scheduling an office allows us to spin the muscle is that it's a great way to see the muscle. Otherwise, it might be turned off for a variety of reasons, but it's spin might be turned on that muscle itself.
Oh, just 1 second. That's my birthday. That could all dope.
Man.
So
That's what we do.
She said it just like
you put it like to your hand, and so you do 30 seconds to then you go 1 minute off, 30 seconds to spin it hot. Because that will do like how the way the pose to it. So like a big bowl of ice water and warm it hot. But you're not making it hot.
Right, exactly.
So you wouldn't, but like hot, right? And so do 30 seconds a minute. That's like the easy thing is my hands to warm up my hands. And do that like 3 or 4 times. And always in on cold. But it creates like a pump.
Not necessarily. They just,
But
they come in with a history of early issues.
or again,
the first baby.
I did that whole
That's the case.
My little child.
I don't see a lot of information because I look out my way, so most of my people are kind of quiet. By the time I see them,
Grandma gonna kick us out.
by the time I see them, they're no longer alive. They've usually been to 16 people. So they've had lives. Massage, therapy, a lot of them see nature paths. They've done a lot of good work and still have them. I end up with them because I got some weird.
Yeah, just for how slow it is, I would take.
And so a lot of times I have to be prepared.
I know, but you could do other exercises. Yes. Or you could do, like the wrist straps. Or I would do that to take the weight off.
I kind of know where I'm just walking around. So I kind of, a lot of times.
It's so funny. I feel like I always like to get tested. They don't have time to chill out.
Kayla and I were talking about potentially meeting and like, I mean, I guess we could do it on Monday as well, but reviewing this or making it more like palatable. And I don't know, like maybe like smaller group. So we can, because the Mondays are great, but we're kind of just reviewing for everyone, which makes sense. Yeah. But like, I'm like, I wanna.
I think that would be good. Now we're gonna start again going over information
Yeah,
we've never seen before.
Yeah.
So
Yeah. Exactly. And
we can
then,
figure something out.
and then we were just talking about like the application of it too. Like, there's so much that you learn, and we're like, we want to practice it, but how do we bring it like to like a clinical setting? Because we're NDs by trade, and nobody does. Not many of us do AK. And so,
I think that'd be a really good idea.
yeah, like, okay, let's figure out like how to apply it and like
yeah,
use it in an appointment, and then
Gotta let it
yeah, work on that like with each other.
Okay.
Yeah.
Yeah, if we can figure something out.
Cool. And I know guys are in school, lots going on, so there's no pressure at all.
No, I would really like to though, because then I feel like that really solidifies the information versus just because sometimes just watching slides. Like,
Yeah, apparently. For 4 years, I was like,
I can barely see, let alone comprehend. So,
And then when he moved over, okay.
any questions? I don't
what
even
you
know.
did.
Can you repeat all that?
So, hey, you guys, you want to review all the muscles that we did in session 1 or 2? You want to do that right now, or do you want to maybe do that after lunch, or you want to learn new stuff first? New stuff. I definitely want to review all the other muscles, but let's see if we can get to. Okay, so we've had this, you've seen this slide before, but so the stomatognathic system, stomatognathic system is comprised of all of these structures, which is basically everything. So, but especially the axial skeleton and pretty much the rest of the skeleton too. So we haven't really talked about hyoid yet, or hyoid last session. I don't think no. TMJ, I'm really anxious to get into that. There's all these different. Each one of these parts, of course, does something when we breathe in and when we breathe out. And we went over the cranial. I think we've got them. Yeah. Remember the cranial motions on in-breath and out-breath. Remember that from last session. Okay. The key ones to remember, especially for now, the key ones to remember are the occiput and the sacrum. On inspiration, the occiput does this, the sacrum does. They basically go into flexion. So remember those, because then the others, of course, the mastoids go posterior, medial, the temporal bones flare. This is all on inspiration. The frontal bone, it's thought to actually infold at the metopic suture. Bridal bones spread on inspiration. Everything goes like you're like a transformer. These plates come out. Sacrum flexes on inspiration. The innominate go flare like the temporal bones, and the ischial tuberosities move medial and posterior on inspiration. So, remember that from last session. These are the parts, all the different parts that we can, that are moving. Nice to familiarize yourself. You guys have skulls. Some skulls around here somewhere. I think I threw this slide in here because it's a good, you can print this off. It's a good reference to see. Just review CSF, very important. Keeps the brain from getting all banged up. Important for nutritionally supporting the central nervous system, carries waste products away, provides cushion. I think it's a major transmitter of chi. Sphenoid is the keystone of the skull. Sphenoid articulates with all of the other cranial bones. Remember that? Sphenobasilar, very important. Affects all these things. Blood pressure is interesting. I think I mentioned this before. I do CDL physicals, so a lot of times I do blood pressure on, I don't do blood pressure on everybody, but I do it on these CDL physicals. And a lot of times these guys are kind of borderline. I can only pass them if they're below a certain level. And more often than not, if they're kind of borderline, I'll check them for what's called a glomellar fault, which is a cranial fault. But a temporal bulge would probably be the same thing. But I'll clear the cranial fault, even though they're not there to get treated. And then I'll retest their blood pressure. And I've seen it drop 15 points. Now, usually it'll drop 4 or 5, which is enough to get them under the line where I can pass them. But, and these aren't, a lot of times these guys aren't patients. They need to be. But, so it's, and I've seen this repeatedly over the years. It's not something I just saw a few times. Something I would, I can really depend on. And so cranial work, if you've got somebody with blood pressure issues, anxiety, all kinds of stuff, always think cranials. Cranials, if you don't know what else to do, check them for cranials and fix the cranials. Just do inspiration assist, basilar. It's amazing what you can do as far as helping them. So we're going to learn. Okay. Oh, I needed the slide to dig it around. Okay, so here's category 3, 2, and 1. Fix that. So category 3, it's really a dysfunction at the sacrum and the L5. It's like a loss of integrity at the L5 S1 area. Category 2, we learned last session, it's basically a subluxation, i.e. fixation of the abdomen, particularly. And then category 1 is an overall torquing of the pelvis. So it isn't just the pelvis, it ends up torquing clear up into the upper neck and skull. That's why we'll see a lot of times the temporal bulge is kind of a corresponding torsion of the skull that's caused by growth. So anyway, AP sway, AP meaning There'll be an AP sway this way, but around, it will be around the bone. I rarely see, when I check posture on every patient, every visit, but I rarely see somebody stand there with a perfectly balanced pelvis. They almost always stand there and there'll be some of this going on. Not necessarily a cat one, I look at the rest of the spine to see if the whole body's torsion. So a lot of times there is an imbalance between the pelvic muscles. And it could be down. But it's interesting when I see somebody who doesn't have that. Most everybody, of course, usually when they're in my office, they need to be adjusted. So, so the way we find a category 1, this is where our minds have to kind of turn things upside down. Category 2 is a one-handed TM. Category 1 is a two-handed TM. This is how it is. So 2 hands for category 1, 1 hand for category 2. Remember that. So a bilateral contact, TL, and then if you get a positive, you have the patient put both hands over one SI, and that's going to give you the side that is quote unquote in lesion. Now the blocking, so the other difference between a Cat 2 and Cat 1, the blocking with Cat 2, you almost always do supply. Blocking with Cat 1, we always do prone. Blocks go opposite to the challenge. The challenge is once you, well, I'll just do it, and then we'll go back through the slides. If somebody have category 1, anybody have a category? Anybody have stiffness or feet? There's, you can therapy localize with Cat 1.
Just further down the road, brother.
So first, I'll have you just sit facing back. Now, I'll usually use, if I'm doing the screen this way, I'll use a lower extremity muscle with pushing. Use a piriformis. Now, put both hands one over each side. Make sure their hands are touching. Yeah, see that? See that? That's a positive. Okay. Take your hands away. He's trying to be strong. Back there again. Okay. So that's positive TM. So now I'll usually have them TL again once they're prone. Then I'll just copy for the PSISs. And what you'll see is they'll be kind of like, is there kind of. Then I go down here to the sacrum, and this sacral apex is drug over that way. What would you think that would be? What you know so far about muscles in this area. This sacral apex is kind of listing a little to the left. What I think you think possibly is going on. What? Even someone who took it last year. Piriformis. This piriformis is that's the way you want to think. When you think sacrum, always think piriformis is a major sacral stabilizer. The sacrum is not stable. So, now it's as he's laying there, non-weight bearing, it's already starting to shift. Like it just actually kind of so that. Now, if that muscle is hypertonic, it should weaken, stretch. So he's got a hypertonic piriformis. The category 1 may fix it. But I'm going to move this way so you can see what I'm doing. Now I'm testing what muscle? Huh?
Hamstrings. That's what they said.
What muscle am I testing?
Hamstring.
Thank you. Sing it out. I think maybe I have to have my hearing. My hearing was fine a few years ago. Maybe I need to have it tested. All my friends are getting hearing aids. It's just freaking me out. It's just so weird. One of my very best friends, we've been friends since the 8th grade. I see him all the time. And we're sitting there talking and he's doing this freaking hearing aids. It's like, oh my God. So I keep thinking, when is it my turn? Okay, one hand. Friends of mine are getting cataracts removed. It's like, oh my God. Okay, so we get another positive TL. So now put one hand over the other. Now that's not the involved side, right? Otherwise it would maintain. So one could ask, somebody's going to ask me this, maybe not. Why can't you just do that on both sides? And you could. This is how we do it. So we know this is the involved side. What's that mean? That means that's the side that probably is in lesion. Now I want to go up here to his first rib, and I want to look for tenderness. Any tenderness? So it's like here. Just works. So rib tenderness. Okay. Now, where's the blocks?
Will you check that piriformis on the side first? You're saying involved side on the left, but that's a hypertonic piriformis.
That's the way it was tested. Yeah. And that one's a little mushy. If I really crowd it, yeah. And that we should clear that. Yeah, but yeah, that's it. Okay, so this is the involved side. Where's the blocks? Now, see how so I'm going to challenge this way, this way. Test a strong indicator muscle. And let's go back to the hamstring here. It seemed to be pretty. So this PSIS and the opposite ischium. Okay. So the other PSIS, the other ischium. Okay, so which side? It's this side. Yeah. So it challenges this way. My blocks go the opposite. See the purple circles are the challenge, and his challenge is the same way, and then the blocks go down.
His challenge was the opposite of static.
It was dynamic. Yes, dynamic challenge. Rebound challenge. Yeah. So it was a rebound challenge.
Pushing down together, and it's going to go further into lesion when it rebounds. And so that further into lesion causes the weakness.
Bounce, 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 further into lesion. So I want the blocks to take it out of lesion. Because right now this is in lesion this way. So I'm going to be putting the block here and here.
That separates.
No, opposite. That's the lesion.
Yeah.
The bones are.
I went dyslexic there. Okay, so then I'm going to bring this block in here at an angle. This block comes in front. Oops. Is that okay? And now, a lot of times you have weak hamstrings to start with. Sometimes I have to use the piriformis as an indicator. So strong. Because one of the common things you'll see with category 1 is weak hamstring. But if the blocks are right, number one, this was strong in the clear. It should still be a little bit anyway. Less Okay, so now the blocks are okay, and I could go back and challenge just to be ultra thorough. And actually, you know what, that's sometimes, yeah, good, so that it negates the challenge. So I'm gonna leave that, go right here, is that still tender? Okay, so I'm gonna have you breathe in and breathe out. So I'm doing an inspiration assist on his sacrum. Now this is something I always do with this, but it's not necessarily part of the protocol. And then, but what is part of protocol, monitoring first routine. Is that any better? It is. Is that any better? A couple more times, breathe in. And again. Basically, I'm doing, I could do this without the blocks too if you had just a straight inspiration assist sacral. Now, how do I know when the blocks are done? Hamstrings go weak. They'll go bilaterally. That means the blocks are, they've made the correction and now they're kind of pushing it the other way. The way I look at it. Now make sure your hamstrings are strong again. Go ahead and TL for me. Push, push. Now that's pretty good. It's not showing that way. Now just take one hand away. This hand back here. Now what am I testing for? Since I've got it here.
Category 2.
Category 2, and that doesn't show either. Okay. Now sit up, please. So we tested him seated, which puts a lot more stress on his pelvis than obviously supine or prone. And so that doesn't show. I'm happy with that. Now, category 2. So that's still good too. Now, let's see. I never got the witness. Did I get the piriformi to normalize? So that strong. So neither one of them wants
I was just curious when you were saying that the way the sacrum was, what side was weak and what?
Yeah.
Did you find that pattern the same?
I find that this hypertonic is always going to drag the sacrum
This side,
over. Is that tender there? So that muscle could just need a little bit of spindling down since we spin. Yeah, see, it's not responding. Okay, let's just spindle down. And he probably has other things going on. Complicated man. Yeah, there we go. See, I'm trying to weaken that, make sure that it'll inhibit. The first time I spindled down, it didn't really inhibit it, so. There we go. Now this is just a little fascial flush, kind of an old Rolfing technique. I'll use after I do any kind of work. Any kind of sacral adjusting, I always try to make sure these muscles are as happy as they can be. It's tight. Push in. Push, 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 push. Good. Let it go. Push in. Good. One more time. Push in. So, yeah. I think, sacrum right now is sitting really square. If he walks around a little bit, maybe that'll change. Let's see. Actually, one more, since I got you captive here. Take both your hands, put them in prayer position right over your sacrum. Breathe in. Okay. So he has sacral wobble, which is the neck here. Let's stay right there. Okay. It's perfect. Couldn't have planned this better. Maybe I could have planned that better. Okay, so category 1, we're going to all do it. I'm sure there's half of us have it. To some degree. 2 rules with Cat 1 is once you determine the challenge direction, then where you're going to put your blocks. When you, I just do the sacral inspiration rocking. That's what I do. But in the classic protocol, you would kind of gently kind of mobilize the SI while on the blocks. But you only would push, like in this example, if this was the involved side, his involved side was his side. Yeah, it was opposite. Then you wouldn't thrust in the involved side, and you wouldn't thrust into a block. So that would leave you with being able to thrust, say, down here on this one. But I don't do that. I do the sacral rocking. I think it works better. Patients seem to respond to it better. But for your test, you're going to be mobilizing over the involved, the uninvolved side, and only if there's no block under that. Now, I want to
Scroll down. Sacral wobble.
yes,
Yeah. Go through like
that's right.
go past all the cranials.
Oh, okay, I thought it was right after that, but okay, shoot, all right. Okay. Here we go. Okay, sacral wobble. Okay, so category 1 is kind of a torsion of it's like the pelvis is doing this all the time. Then it gets injured, or the muscles get out of balance, or something happens, and now it's doing this. That's category 1. Or it's doing this. That's category 2. It's not only positionally out, it's functionally out. So what can result? Like you walk around with that, pretty soon the normal figure 8 motion of the sacrum in gait starts to get fucked up, and that's what sacral or sacral wobble is. So it's kind of a finishing technique to a category 1 if they test for it. So the way you test for it, say you've just completed like we just did, category 1, tested good. Still have this reliable indicator muscle. Now, once again, prayer position. That's the TL for sacral wobble. Then you have them take a breath in, hold, and it strengthens, breathe out. So he strengthens on a breath in. This is one of those techniques where phase of respiration determines how your correction is going to, where you're going to correct, what direction you're going to correct. So there's a TL. So if you have weakness, you inspire, expire, you find the phase of respiration that needs to be there. So if it's on inspiration, I'm going to contact his sacral apex and his dominant after I challenge, and then I'm going to correct on that phase of respiration. So I'll just do it. So we know that he TL'd. We know that he strengthened on inspiration. Now, if I challenge, now we knew we had a sacrum kind of this way, so I'm going to start here. I'm going to challenge here and here. So I grab the front of his innominate, and my thumb's on his apex, and I'm just going to challenge it this way. He goes weak. So I got lucky the first time, but I kind of had a clue. I could go the other way. So it seems to be this one here, which would make sense with the sacrum. Okay. So once again, the breath in, breathe in, and hold the breath. Okay, so that's how I'm going to correct it. So it's just like a cranium, only it's a sacrum. Okay, so I use the heel of my hand a lot just to kind of save my fingers. And once I get a good capture there. Now, I'm holding here, breathe in. And as he does that, kind of what the arrows are showing. Now remember, as we breathe in, the sacrum flexes. And the innominate flares. I'm basically reinforcing that motion. Go ahead and the prayer position on your sacrum again. So he had a positive TL. And breathe in. Hold. Yeah, okay. Yeah, we didn't get it all. That's why. Breathe in. The beauty of being able to adjust and evaluate in real time. Otherwise, I'd have to just do it and go, okay, Mr. Dean, we'll see you in a couple weeks. See how that does. And now I know if he has it, and I fix it, position. Fine. Read it.
You're doing this towards the unaffected side, right?
I'm doing it on the side, I'm actually on the unaffected side, as pertains to the category 1. But as pertains to the sacral wobble, I'm going on the side of challenge. There we go. Oh, that just moved. Okay. Okay, there we go. Breathe in deep. Yeah, that just, sometimes they just, we're asking a lot of this indicator muscle, but it seems to be, yeah, okay, now prayer position, please. Yeah, we're good. See, it took me like three shots to really get it. And I finally, that last time I could actually feel it, just kind of freed up. You could feel it, yeah. Thank you. Great example.
Could you possibly demonstrate the expiration just to, I don't understand it.
What's that?
For the expiration,
The expiration.
telling you to contact under this apex.
Yeah,
One side of the
yeah,
posterior,
that's tricky.
one base, yeah.
Yeah. The expiration, you get as much underneath that as you
From
can.
the anterior.
No, you're on the back, because you're kind of hooking it up underneath where the sacral spinous ligament is. Kind of find that and follow that to the, you know, and then your hands on the sacral base. It's trickier. Unfortunately, not as common. It's harder to do. But and you know, they're usually on inspiration, like most cranials are using. If you keep finding expiration assist on people, better check them for switching. A lot of times they're neurologically. You both of you had hands up. Where?
Can you explain the difference? First thing you did, you corrected in the opposite direction of what you corrected now. How is that the case that first you tested, let's say in this direction, and it was weak, so you wanted to correct it in the opposite, and then you tested it again in this direction, and now you encourage the body to go in that direction?
It depends on what you're testing. a category 1, based on the finding, is that it's like everything has this different way of fixing it. So that, for the category 1, you correct opposite the challenge. And then in this one, you actually correct in the way that you find the challenge, based
Same
on
side.
what you're finding.
It's
Isn't it
two
the rest of the
different,
challenge,
it's-
they go weak,
it's-
that's a lesion, don't want it in that
exactly.
way.
You don't, if you're doing a rebound challenge and it bounces back into lesion, you don't want to do that. It means you've got lesion. So the idea is that you're getting that joint to normalize in its position, and hence get the nervous system to kind of normalize its conversation, so that the muscles can start firing appropriately, synergistically.
Based on the question you're asking the body, like with the categories, like you're putting it further into the lesion, so we want to correct it. Whereas with this one, you're asking the body a different question.
In both, yeah, because with this one,
How are you asking?
with both of them, with both of them, I'm challenging the sacrum's relationship to the anus. The initial one is kind of the more kind of gross portion in the pelvis, the category 1. Now, underneath that was also some aberrant fixation that had to do with the way the sacrum moves in gait. But that would have been harder to find on its own. He might have tested for, a lot of times if you test them for sacral wobble right off the bat, they won't show it. If they have a cat 2 or a cat 1, that's kind of like a noisier to the nervous system. That makes sense? Yeah. But yeah, they're two different techniques. It's just that they're both involving the relationship to the sacrum.
I still don't understand why I mean, if I'm the only one to ask a question, I can ask later.
No, I'm sure you're not the only one that's not sure. Maybe I'm wrong. Maybe you're the
With
only
the
one.
wobble, why did you put it in the direction that you did?
Because I remember the sacral wobble, what's kind of distinguished about this is when you have them breathe in and out on the TL, and if the breath in negates the TL, then you know it goes this certain way. If the breath out negates this TL, then you go the other way.
There was the rebound. Didn't you do a rebound, like you press and then let go and then test it? Versus held your hands there
It's
as a
not
TL.
really a rebound.
Wobble more static.
Yeah, it's more of a static direction. I get where you're at now. I
Is
think
that
I
what
get.
happened?
I think I get you
Like,
now.
why, if you challenged it in the direction, why are you correcting it in the same way you
Actually,
challenged it?
Somebody,
I have an idea.
huh?
Can I show something?
Sure.
Use one of the skeletons. It'll be easier.
So this particular correction has to do with the breath and not necessarily the challenge.
So the dynamic challenge that he did on me was this direction, bouncing it, right? Dynamic, and then test it that way. For the wobble, he didn't do that. He pushed this direction. He just pulled and then tested. So there wasn't a bounce on the sacred wobble. It was a static piece, pushing here, pushing here.
So is
was
it,
a
once
rebound.
you let go,
It was a rebound challenge. It is a rebound.
I think what's different about this is, like you're saying, is the correction is based on the breath. It's not actually based on the challenge that you're.
Well, the slide is based on the challenge. Now, when the breath negates the TL, I don't know if it's right or left. I don't know if it needs to go this way or this way. But I know it needs to go this way and not this way, which is the expiration. So, but I don't know which side. So then he lays face down, or he's still face down. We do the challenge. I do the challenge as if I was in a corrective, which is lifting here and
pulling here. Or, and I did it over here, and this one challenge. So the correction is, it is a rebound challenge, but it's not a rebound correction. It's more like a sacral inspiration correction, which is not really, which, there's a few of the cranials that aren't rebound. Sacral inspiration is not rebound. The sagittal suture spread is a direct correction. There's just a few that are direct corrections, the rest are rebound. Spinobasilar is a rebound. The inspiration assist is a rebound.
Maybe it would help to explain on the skeleton how you tested it, and then when you were done correcting it, what was the direction, you know, like doing it all anatomically.
Okay. Go ahead and do that now.
Does everyone else want that? Okay.
All right, so you guys can come down here if you want. Let's make sure. So let's go back here. So this
It
is
doesn't
how
make
we
sense, it's just what they find.
So actually, yeah. So this is talking about this figure eight motion, which basically when we're walking, the pelvis is doing this, and the sacrum is kind of doing this figure eight. That's when everything's working well. What happens is it becomes asymmetrical in the way we move. So this is where we start, TL over the sacrum, and you have the patient, if it's positive TL, you have the patient breathe in. Patient breathes in, negates the weakness. Then we know that it needs to go this way. Meaning I contact the sacrum and the anterior leg span. It's fine. So I know it needs to go this way. I can, but the reason I need a challenge is determine, do I do this side or this side? Because I don't know which side yet. I'm pretty much just kind of pulling the anomaly. I'm kind of trying to mimic that flare that's supposed to be happening when the body breathes in. And then here, I'm kind of, vectors kind of like this. Kind of like that as arrows, but does that make sense?
So
you're trying to, yes, you're trying to make it go into the part of the figure eight that's not looking into. So anyway, so that's how you correct it. You correct it on, so I challenge it to see which side. But I already know I'm going to correct it on inspiration in the case of D. And I know I'm going to correct it because of the challenge on the side that I did.
Okay. Can you show the challenge, and then if it's weak, if it's not corrected, no, if it is corrected on inhalation after you do that challenge, then you're further going to urge it in that direction?
That's I see where you're, yeah. This is kind of like that. Yeah. This is kind of different than the other dynamic. I've been doing this so long, I've kind of forgotten that that's how you correct it. So, yeah, okay, so here's the challenge. I'm going to be here, like so. I'm going to be, this is loose, but I'm going to be creating this kind of motion. Test the muscle. Over here, do the same thing, test, muscle doesn't do it. So we know this is the side we want. Otherwise, we didn't know that before. We just knew that that's.
Could you do that?
Knew we needed to go on inspiration.
Dr. Dombey, can you do that one more time? People didn't hear you.
Turn.
Okay, so challenge, so positive TL negates on the breath in. Challenge, I'm going to go here to the sacrum, not to the ischial or any of this area, but right here to the sacrum. I'm going to get right on the side of that. I'm going to do this, and basically what I'm trying to do is create this motion right here. Challenge that, And then if we can, so that's the correction. So they breathe in. But it is a rebound correction. It's a rebound. Yeah. Because it rebounded back into lesion. It's a rebound. Breathe in. Let it go. That makes sense.
So if it goes weak, then do the muscle test.
That's a rebound, positive rebound channel. That's the side. You already know, instead of having to determine if it's breath in or breath out, you already know that because that's what we found with the TL. Yeah. In category 1 wouldn't necessarily involve breath. Oh, I would do either 1 or 2. And if there's a 2 and a 1, which often there is, I would do the 2 first. Oh, yeah. Yeah, this is like a finishing technique, kind of like the thin layer of muscle.
Well, you corrected category 1 and it came back, and you could correct category 1 again and then check for it.
Get them in category 1.
No, I mean, really, it's
Or
like-
if you do, they get off the table and they're like, oh, that doesn't feel good, and you're like, oh, shoot, I blocked it the wrong way.
the
And you
beauty
put
of
it back on the table.
the beauty of these respiratory corrections and these slow motion is it's pretty darn hard. It's really, you got really, where there's other kinds of adjusting where it's pretty easy. So, all the years I've been doing this, I'm starting to think, at first do no harm. Maybe at first. So, I mean, yeah, it's always tempting to just start running the bones and go. But, yeah, so, so you're not gonna. But the thing is, the body will hide things. You'll find a lot of times a sphenobaselar will hide other kinds of gradients. A lot of times, a category 2 will hide all kinds of things. A subluxation in the lumbars or the thoracolumbar, right? Override a bunch of other stuff. Anyway, we want to workshop category 1, and while you're there, this is the expiration, the one that strengthens on expiration. You got to get under the sacral apex, a little tricky. Kind of like doing a sacral spinous ligament.
Can you demonstrate that on me?
Yes. So the correction for the inspiration is like so, right? So the correction for the expiration is you get under here best you can. You take your hand and you get up here on the sacral base, and you challenge this way, challenge this way. Whichever one tested positive, you make that correction on expiration. So if you challenge this way, you would be I'd be under here as far as I can get. Can't get under there too far without hurting. And then we go breathe in, breathe out. In. Now, what am I supporting? I'm supporting normal sacral extension, which is what happens on expiration. So normally the sacrum does this on inspiration, this on expiration. So basically, I'm supporting that with this correction. So it's like a dress. That is like a dress. Anyway, do it that way. It's amazing. It will a lot of times make people feel freer in their hips. But it's a finishing, more of a finishing technique than major. Does that make sense? We should do this. Let's see if we get to the end of this section. Okay, so yeah, we can take this up after we. This is okay. So let's take this up. You guys want to do category 1?
Yeah.
Let's do category 1. And then we'll do
So good. Oh, it's so weird though.
That's like a one step, so now you're like,
So start with, once you tear up, do a posture exam on your patient and look for if there's any indications of AP sway, torsion around the plumb line. See if there's any side slip. That would indicate it's CAT 2. Just look at that first, and that could. And if you have a question, call me over. Call Dr. Whitney over. So this is going to be your TL, quick review. And then once you TL, you don't worry about breath or anything. This. Put it face down, and you challenge PSIS and ischemia. One side, test the strong imitator muscle. Whichever side has a positive test, you put the blocks in. One block goes at an angle just like that. And then you check for first rib tenderness. And monitor that as you are, as the blocks are working, and that's what I would recommend, just kind of putting your hand on the sacrum and having them breathe, concentrate on breathing and kind of riding that sacrum with the, find that it will be clear of the capillary quickly. Then you can monitor this first rib tenderness. So let's see if we can find some.
what's the vector of force of this?
It's pretty much PA.
Oh,
Yeah, it's so posture, and then don't spend too much time chasing other stuff that you might find. Posture, and then have them sit, find strong piriformis. Hopefully they'll have a strong piriformis. Have them TL, double TL, and see if we can. Just keep it simple.
anyone need a partner?
Oh, and your
For your now also
we have one set.
Didn't want to.
Oh, okay. Do you typically just turn off the meeting?
Yeah.
Yeah, cool. I want to